Edward or Jean-Paul, if you can speak to, of all the things you talked about, what is the greatest barrier for you? And there's many, many things you have to overcome, but when you think about expanding this, what's going to be the biggest barrier? Is it going to be the internet connectivity? Is it going to be the ability to have quality speakers? Are there other structural things? What would be your perception of going from where you are now to something even bigger?
Okay, thank you, Mohit Bandari. I will start. On my side, the first barrier is behavioral change. So when something new comes, there's a little bit of resistance for people to go to that new trend. So people want to stay in the traditional way of doing things. That is natural. So some people want to remain stuck in the Stone Age. And they present a bundle of reasons showing only the disadvantage or the challenges. However, with time and with the results, people come to realize that it's really important and they come on board. So after that, there are now technical issues such as how to use the software. So people need to learn how to use the software. Sometimes during a meeting, some people, they have their mic on and we have a background noise which comes and disturb, and you need to be consistent to remind people. So, and they don't do it intentionally, so they have to learn how to use the software. And we have also technical consideration like the quality of internet. And most of the time, we may not have a permanent internet at home. We are using phones. Sometimes there are interruptions, and also the providers. And in some cases, I've seen in some cases, as I was giving some lectures, it's power problems. You've seen someone who is a speaker who's supposed to intervene is in a room somewhere, and power goes off, and it's a problem. So those are the challenges. So behavior change and also technical issues. But with time, when people see the results and they follow the trend.
Yeah, that's very good. I think you've raised a lot. I don't know, Brad, if you have any comments or thoughts. You participated from the virtual side. So, but what's been your experience?
No, I was going to ask Edward what he thought about this, because you know when we first started doing things, you guys were in a room like you'd mentioned, and I was kind of Skyping in, and now we've all moved completely to Zoom. I think that's one of the questions is, you know, as we move out of COVID, is there going to be a role for this combined, you know, are some people going to be in a room? Because I know when you're in a room with the trainees, say we're doing a session, it's much easier for you to get that interaction and pull people into the discussion. When we're in Zoom, that discussion happens. But do you think there's a role for a mix like that, or do you think we're all going to stay on like a Zoom WebEx type platform?
Thank you, Brad. I think it's going to be a blend. It's going to be a blend because COVID is here to stay. That we've come to realize. And because of that, we're not going to have as much close social interaction for quite a while. So considering the old way of a crowded room of learners sharing one screen, changing to the current social distanced individual computers and phones. I think the blend that's going to come about is as the normal comes into effect, more and more people will get to either congregate in a room, but with fewer numbers, and then those who can't make it in the discussion and still have the interest will have their own individual connections. I believe Zoom and the new platforms are taking over because the connectivity, the service providers are being overwhelmed by large numbers online in the current situation, and that has slowed down the ability to access some of the interactive platforms like Skype. So The new trend is Zoom, which has not been affected in that way, and also having smaller groups together, and then the additional members separate but still connected. I think that's the new way.
And I know that I know that congratulations on your new chair. Patrick is looking at Mr. Sichimpi is looking at incorporating more virtual stuff too to the program. How much is too much and how little is too little? I mean, people can get some Zoom burnout. What do you think is a good amount of virtual learning to incorporate? You're muted there. Either, yes. Both of you guys.
Yes, please. Thank you very much. I think what is needed currently is to fill the gaps that are not being met by the interpersonal interactions. So there are always gaps to fill, and identifying those gaps will be key. Is the gap in the knowledge? Is the gap in the skill? Now that's where the role comes in for the virtual learning, to fill that gap. Again, virtual learning has proven to be cost effective. We don't have to travel. Even with the airlines down and the airport shut, we still get to interact. We still get to share that knowledge that makes a big difference in practice. Mm-hmm. So I think the two, with that in perspective, will make it possible to keep using the virtual learning and yet not getting rid of the old methods of interpersonal learning. I don't know if Jean-Paul has another perspective.
Yes, something to add. On my point of view, what is on the ground here in Africa is the virtual learning on the side of education, whereby we exchange knowledge. And it's a new thing. It started in the commercial area with marketing and so forth. Now it has come in medicine. Everyone is talking of Zoom, but it is really helping when it comes to knowledge, exchange of knowledge, and really we are getting it. But there's the other aspect. When it comes to surgery, it is something we need hands-on. And we have challenge, even in developed countries whereby there's a problem of exposure. Now, when it comes to us, it is again a little bit again bad. I was in Ethiopia and I saw something there a little bit special, whereby, okay, they have a big number of residents than Uganda, you see, being the second large populated country. So they had at heart that thing of increasing hands-on of their surgeon, because at the end of the day, we finish our training, but we don't have enough. Some cases we're supposed to do either we did once or twice or even zero. And the first encounter is in real practice and it's a challenge. So they came up with something, apart from the teaching hospital. So every year they send all the residents from second year up to fourth year in other big centers with orthopedic services in a small number with an agenda to reach a certain number of cases to lead their case with instruction. When it is a resident on that case, they leave the case under guidance. Even if it was supposed to be 1 hour and it takes 2 hours, they leave it. So they are trying to bridge to fill that gap of hands-on. Now, when it comes to virtual learning, there is that aspect which is not yet on the ground here. I haven't yet seen it. Using those simulations, it will be a good perspective and to lobby for that, to try to fill that gap. Because during training, there is a fight between residents to lead cases, and it's a problem, and also between residents and the junior surgeon who had also that gap and they want also to fill. So at the end of the day, there's a problem. Now, virtual learning in that aspect will come and improve the quality of training. Like in Rwanda, I came to learn that in Rwanda, when you complete orthopedic surgery, they give you a mentor. So for 1 year, so you are performing surgery under his guidance before leaving you alone. So now virtual learning will come to try to simplify things. That's what I wanted to add. Thank you.
You think I mean, this would be a question for everybody. do we think that these virtual, these VR things have the fidelity to help us develop surgical skills? People who are marketing them would tell us absolutely. And the question to the group, I guess, to everybody here, do you think it's a reasonable adjunct? Do you think it's worth the potential costs? What do people think about those? Anybody can comment.
I mean,
Okay,
go ahead.
I will say something. I think it makes a little bit of difference, though it is not enough. There are studies on it, and they try to compare a resident who they go to simulation, and after the simulation, now they go to real practice on those plastic bone in lab. They come to realize that there's really an improvement in the scale that was published in some papers. On the other hand, I have access to a simple thing. It is not really those big things so just a simple app. It gives you all the steps and so forth. You see, it tries to give you a little bit of more confidence when you go in, though it is not enough, but it's something, because surgery is also a gift. They say, see one, do one, teach one. So sometimes you didn't see one, or if you saw it, you were in a crowded room and so forth. But when you look at it a little bit close, you using that simulation, it makes a little bit difference. That is my point of view, and I don't know what other people have to say.
Here's a question for you. What do you guys think the appetite is like for instance, Mohit and I, go do a Pune trauma course, and we lecture, and then we go to theater and they broadcast the surgery. And this is a fantastic way to see one. What do you think the appetite is for that? Both from a patient point of view, from a training point of view, and you guys both do public and private work, to be able to take that, what you're doing surgically, and put it out there. It's having done it as a surgeon, it's a little bit nerve provoking in the first couple of times you do it, but it's an amazing learning experience. What do you think? Is there an appetite for that kind of thing? And you think there's some ability to do it, Edward?
So this is to do with the virtual reality.
Yeah.
No.
You're doing the surgery in Nakasero. The residents are watching you at Malago, and you're going back and forth and discussing it.
Yeah, but Brad, I think to clarify for Edward, it's not a virtual reality platform. It would just be televised or virtual surgery in the sense of you would be operating, and it would be like the same way here on the screen. There would be people being able to visually see it live.
Right. Yeah. It would be a virtual broadcast, virtual meeting.
Yeah, live surgery.
Do live surgery.
So live surgery definitely has a very big impact in training of future surgeons, the residents. It does have a role, and just like Jean-Paul mentioned, seeing something begins to grow a kind of understanding of the practice amongst those in training. Even someone who's already experienced may see something new happening and pick that up. So in terms of training and improving the learning, the live surgeries have a very big role. And I think the appetite for it is growing as more and more surgeons and residents have had interactions with different societies. For example, via conferences. The last conference I had attended was the Asia Pacific Conference. And the live surgeries really made a very big difference in appreciating the content that was being discussed. So the role is there, and it's quite big.
Let me ask another point. I think you may have addressed this already. Oh, sorry. Is it okay, Brad?
Yeah, no, someone had their hand up, but
okay. I'll let the next person speak. I just wanted to get a sense of, right now, most meetings are struggling with one thing. Do they go fully virtual, or they do a hybrid? And I think we discussed this a little bit. I think you talked a little bit about it, right? Having a local group of people interacting. And the reality for us right now is in the next several months, international travel is very difficult, and I suspect our borders are going to be blocked for people coming in and out for numerous reasons, but the obvious being infection risk. What's your take on the future, and even after all of these policies are done, of the ideal meeting being a hybrid meeting rather than all in person or all virtual? For anybody.
I think if I look at it in the future, hybrid is the way that it's going to go, a hybrid meeting. And the reason for that is the old way of doing things, wherever there's opportunity to use them, the personal interactions, the hands-on in the OR, the hands-on in the clinic, that opportunity will be taken.
Yeah.
But wherever there's a limitation, then the use of the new alternative, the virtual method, will be employed. So I think we're going to start seeing a lot of hybrid training and learning.
Dr. Bhandari, may I come in? This is Dr. Pankaj from
yes.
Delhi.
Hi, Pankaj.
Yes, I agree with Dr.
Yeah.
Edward. We need to blend the two, hybrid.
Okay. Pankaj, did you have something you wanted to say?
Yeah. So I was just listening to the whole conversation, and I was wondering, to me, still having a one-on-one meeting is probably the best way, but we are not in any position to do that, as you rightly said. So as we go ahead, rather than having, I think these virtual platforms are offering a lot of promise. And as we already know from multiple different platforms like UMedi, where we see videos which can add value to an average surgeon's surgical skill. But if the same surgery is being done in the same setup, as in a surgeon of Uganda performing a surgery, and viewers also from Uganda, they relate more to it, because sometimes they think they don't have that kind of equipment or that kind of a setup. So I think that is one very promising thing in the present times. And if I have not missed, I'm sorry, you want to say something?
No, please go ahead.
I would also like to bring in the point of podcasts. I don't know if you guys have discussed it already.
No, we have not.
Okay, so I was wondering, podcast is something which is very, very useful. I mean, every time we are not in a position to, really see the surgery or understand. I mean, let's say if someone has an interview with you, Dr. Bhandari, and you have some important points to make, it's a bite-sized information, 10-minute, 20-minute thing, which a person can consume anytime while traveling or while even, sitting at home. So that is another promising thing, I guess. And I would also like to bring in a combination of blogs with the podcast. I have read few of your blogs. They're wonderful, very informative, with multiple backlinks to go and read about it.
Yeah, so I think Pankaj, you raised a couple of great things that, I mean, the modern day meeting will do. So every meeting that we have that is recorded allows people to say, well, if I can't get to the meeting, can I still consume content now on my own? And I think so much about surgical practice is I need to have it customized to my interests, only what I want and when I want. And I think those are things that we have to be looking at when we're designing the new world of hybrid, virtual, whatever that may be. I do think the big limitation of in-house is that if you miss the in-house meeting, you miss the content, right? And most big associations, so Pankaj, you're in India, you're likely going to be looking at what's happening with the Indian Orthopaedic Association as an example, as one of the meetings coming up. Whether they have it or not, if they have it, great. You may get content, I think everyone tries, but it's never the same as if it's been tailored for you and provided in a curated way. I wonder in Africa if the same opportunities are available as we think broadly about all the different ways to provide information. And I think the point is that for the average person, and I'll ask you all, how much time can you literally spend at one sitting watching something? I think Pankaj said 15, 20 minutes. For some people, it would say 5 minutes, and so how do we distill meaningful points into small bite-sized learning opportunities that can be consumed by surgeons at their own time? I think that's the question broadly, but thank you for raising that, Pankaj. Maybe I'll start with you, Dr. Petrozor. Do you have any thoughts on that one? Because I'm sure you do, actually.
Well, yeah, I have a lot of thoughts on it, but and some of them speak to some. Anyway, I have a lot of thoughts on it, and
Yes.
I think that, you know, we in Canada have a problem with the intraoperative stuff getting out from confidentiality points of view,
Yeah.
and all of those
Yeah.
can be overcome. The other problem is, at the end of the day, people are going to end up putting out a lot of bite-sized content,
Right.
and so that either comes at a cost of altruism,
Yeah.
meaning I just
Yeah.
want to put out the content,
Right.
and then all of a sudden, as more people put out content, then some people say they want to get paid for this, and then all of a sudden there's this whole avalanche of, oh, now we got to charge people for it. So, and I don't mean that in any sort of selfish sense, but that's the way you've seen social media grow, right? Because now people are making tons of money on their Insta profiles and their Twitter profiles and all that sort of stuff.
Right.
And so I think there's a massive issue there that might start to happen with increasing. People may start to try and take advantage of that. So I don't know. And again, I'm just thinking out loud. I'm not even asking a question.
Right. You know, the one thing
I think big organizations are going to have to kind of think about that content.
Right. I mean, the one thing that's said is that, you know, I know we say you have to visually see the surgery, and I think that's very important, but what if you're able to have surgeons, both in Africa, in India, you know, and internationally, sharing audio clips or podcast clips, 5 minutes of what they would be considered, you know, verbally, the key aspects of a technical procedure that would allow you to be able to understand it. I mean, most operating surgeons would understand key tips and tricks, you know, and not having to necessarily see the deltopectoral approach. They would have a general idea, but it would be, all of you know this approach, but let me show you and let me share with you audio file, key little bits. I don't think we've ever done that. And I think there's always been this perception that it has to be visual, but you could literally walk through, a whole surgical procedure set, audio. There is no patient confidentiality. I mean, there's nothing there to be done. I mean, you could literally do that. And I think it would still be very, very valuable because most surgeons know the broad procedures. What they're missing is tell me what you do a little differently. Verbalize that to me as another option. I see John Paul nodding. I see Edward nodding. Pankaj nodding. So
we have some of those data. We have some of those sets already, which have been put on the shelf because when we started doing competency-based procedural things, we went through with 6 surgeons what they felt were the key points of the operation. About 30 operations.
Well, we
and
should
now
do that.
Royal College has decided that they're not going to go that way and they're going to go with a different score. But we've got about 30 operations that we went with 6 surgeons and did. So we have that.
I guess my question is to both Edward, Jean Paul, to say to Seratin, to Pankaj. Is that something that would be of interest? Is that something that we could make a nice offering as a collaborative effort that would be useful? Yes, Pankaj.
Yeah, I think it will be a very, very powerful addition to the present set of things we are using, because I remember discussing certain surgeries which I'm doing and I'm struggling in some aspect of it with my colleagues whom I think are more experienced than me. And sometimes there are some hacks, there are some practical tips and maneuvers which you can immediately incorporate in the next surgery when you do it. So I think it's very, very helpful if you're already doing some surgeries to, you know, step up few notches when you discuss with somebody who's more experienced. Yes.
You're right. And oftentimes what happens is, I mean, we all know that, so the challenge with intraoperative procedures is, you know, is getting perfect visualization. So sometimes all you see is just this big glaring mass of red and they're giving some detail and you can't see it. Why not simply just have someone like we're doing verbally say, these are the 3 things you must do, show a diagram with the hack, as you call it, Pankaj. That to me would be imprinted immediately because it would be clear and decisive. And the assumption here is surgeons know the procedure. You're just giving them the extra little tips that would allow them to be even better at what they do. It seems to me that's not being done. What we're seeing is, as you said, videos of full surgical procedures that may last 40 minutes, 1 hour, and of which those 40 minutes or 1 hour, maybe 3 minutes or 5 minutes are the only thing you watched for, and you don't have time to waste for 40 minutes. So I'm just trying to find ways to make it efficient as we think about virtual ways to educate.
Yeah, absolutely. No one needs to watch someone open and close and all that sort of stuff.
But it happens, right? Those are the videos. Yeah.
You're right. You could do the whole operation in a minute or two.
Right. Can you imagine saying a situation of 50 procedures where you go to individuals who are the known experts around the world and say, what are the 5 things you do to reliably get, in this case, a successful outcome, and then have them identified and name something you do that no one else probably knows to do, and they'll have them write that down. Pankaj would say, got it, thank you, right?
But you know what would be cool too is to do what my son's talking about. People are doing all these breakdowns, you know, surgeon breakdown, whatever, military person, you know, have the procedure and just have a little breakdown. You see right there, that's the key point. And then
yes, a third party, a second person. So basically having a series of procedures and having an expert break down it, you know, I think that would be very interesting. Again, not being done, right?
That would be great.
We can learn a lot from the virtual world. And I think you're suggesting, Dr. Petrozor, from the gaming world, where we see many, many situations of young children who are learning from other children about how to play games, and they watch other children play the games. That's exactly what happens online. We can be doing that in a much better way. We can learn from them.
I think one perspective we look at is how safe will the surgeon be at the end of the day?
Right.
With those clarified, I think that goal will be met. So
yeah, I think this is a good, I mean, that in itself is a really interesting insight from this discussion. There are many great insights we've had. So superb insight. I also want to just say that we are now quickly at the hour. So we've had a robust, deep discussion. Small groups are always better, as you can imagine. This would not have been accomplished in a webinar format. And so I'm very, very happy that we were able to connect and have a deep discussion. I might ask, if I could, to have Dr. Petrozor say a few words and then leave it with both Edward and Jean-Paul to have the final word as we close out in the next minute.
Thanks, Mo. Thanks, Ori. The only thing that I have to say is I thoroughly enjoy getting together with everybody virtually. You know, Edward with you and the residents over the years, Jean-Paul talking trauma. And I must admit, I'm just so looking forward to, you know, there's always the silver linings, and I think this Zoom platform and just getting together with everybody is one of them here, and just so appreciated the discussions that we have. So that's all I wanted to say. I think it's here. I think it's here to stay, and I think these combined things will just allow us to have even more collaboration. So thanks.
Yes. As my final words, I can say virtual learning is here to stay, because we have gained a lot from it. And we just need to get a lot of that type of learning. Myself, I've gained a lot for it, and I'm always advising other people, other surgeons, especially in our context, to have someone like a mentor from far and so forth to keep boosting the knowledge and so forth and exchanging. And Dr. Mohit brought in something, even if it is not visual, the audio thing. I remember we discussed with Dr. Bright challenges when you are dealing with tibial plateau, how to go and look at the meniscus, how to pull it out, even if it was not like live surgery, but just that discussion brought a lot and revolution. So virtual learning is here to stay.
Thank you very much. My final words are in line with the agreement that virtual learning is actually here to stay. And it has created a way where we've had many challenges. COVID came as a challenge, but in a way it has provided a solution or made it more pronounced. I'm happy that this new way of approaching education, learning, interaction has come up in a very, very, very broad way following this pandemic and the lockdowns that we have had. And from here, I actually see a more accelerated growth in the way education will be done. And in a way, it's going to actually make the way we use our time more efficient, whereby a 5-minute podcast as opposed to a 2-hour lecture means you have a lot more to do. So I'm happy about that, and it's very promising.
On that note, I'd like to thank you. Oh, yes. Pankaj, you want to say something?
Yeah, I just quickly want to make a comment. Usually, we don't face such tough situation. This situation has kind of pushed us off the cliff, and we have to design an airplane while falling down. So we have to come up with new ways and find a way to.
Yeah, and you have to do it basically on the fly, very quickly, very, very quickly. And we are, and that's the great part of it. So thank you all for a great virtual meeting in Africa. Thank you all for taking time. We'll have this recorded and we'll make sure we get this information out to all those who would be interested. Thanks again. Have a good day.
Yeah.